Thank you. Good morning, ladies and gentlemen. Thank you for the introduction as well. We work very closely with the University of Birmingham, so this has been a collaboration between the thoracic surgery department and also the respiratory physicians across at the university. So, why does this topic matter at all? We know now that smoking is the most important risk factor for post-operative complications, both in the short term and also actually in the long-term survival now. There's recently been published some work by Sebastian Lugg in Thorax showing that the long-term results are also worse. Patients, they've also told us in qualitative interviews that they want to be approached by healthcare professionals about stopping smoking. They think it's our job to raise the subject with them, even if they have no intention of quitting at all, they're going to smoke whatever we say. They've actually said, well, even though I don't want to quit, the next person who comes along might benefit from that. So yes, I think it's a good thing that the nurses and doctors and other members of the team bring it up with them. And in addition to that, they want the support that goes with the smoking cessation to try and be coordinated with their routine visits already. We know that the patients that we're seeing will have a lot of appointments with people, whether on the same day or different days, and then having to go and see their pharmacist or their GP or another appointment somewhere else is just something else for them to have to worry about. They like it to be integrated with the same team. We do know that from experience that a lot of patients coming forward for surgery still smoke up until the day of surgery, but when we interviewed our own current smokers, 80% of the people who were still smoking when they came forward to surgery said that they had recently tried to quit. This is important because they're in a mental state where they're ready to try and give up. And a lot of the smoking cessation programs in the community will spend maybe up to 6 months preparing somebody mentally before they give up. But these patients are saying, mentally, I want to quit, but I couldn't for some other reason. We don't know the exact reasons, and I'm not saying it's definitely our fault. It may be that it's the interpretation of how they feel, so it's not all our fault. But it's just something to be aware of, that they're mentally in a state where they're ready and they want to quit. So what did we do? We sent a survey to nationally up and down to 38 centres across the UK, and we asked the healthcare professionals in those teams and all different disciplines within the team how many of their patients were smoking when they came forward to surgery, what kind of referrals or options were available locally for them to help with smoking cessation, and how successful the healthcare professionals thought those resources were. It was advertised through mailing lists, and as you're about to see, there was a good response. So we got 99 responses, which was 95% of the surgical units we had at least one response for. There was a good turnout from the lung cancer nurses and actually also from the surgeons as well. The thoracic specialist nurses were well represented, and there was also a number of other people like medical oncologists, respiratory physicians as well. Now, I've just said that we know that patients want things to be integrated into their routine appointments. Actually, every single centre we asked was making a referral to the community with this extra thing that patients had said they weren't so keen on. Obviously, it's a long-term problem with smoking. It's not just a one-off. They need support in the long term to stay off the cigarettes. But coming up to surgery is a relatively short time frame with the targets that we have to hit. And both waiting times and patient preferences that they really don't want to have to go to their GP if possible. Within that, some centres were saying their services were absolutely excellent and that they had really close communication within the hospital with their smoking cessation services, but also the opposite, hospitals that were saying, well, it used to be good, and they've just cut all the funding and now we've not got it at all. So we're in a difficult climate in the NHS. And then how many patients did the healthcare professionals think were still smoking at the time of surgery? I would summarise that in a lot. But there's also this big proportion where we don't really know. It will be written down somewhere, so it could be found. But the fact that a lot of people don't know might be just supporting evidence that we're not as engaged with the smoking cessation being integrated into their care along the way. So if you've got nearly 20% of your healthcare professional team that don't know whether the patients are still smoking or stopped smoking or whether they've managed to quit if they wanted to, that might just be an indicator of something else going on in the background. And also these rates of smoking. So the national prevalence of smoking is about 20%. So this does correlate with, we think, that people coming forward to thoracic surgery are more likely to be smokers than current smokers than the general population. And then how many people are managing to give up the cigarettes once they've got that lung cancer diagnosis? They know they can have surgery. There's that excitement with curative intent we're going forward. Well, again, I would summarise that in not many, less than half. And although in the 40 to 60%, that looks quite good, they were saying more the 40%. And again, this evidence of even more people who may have known about how many patients were smoking, then they didn't know how many managed to quit. So there's a possible lack of engagement from the healthcare professional side with the smoking cessation support services. Again, this isn't to try and flagellate ourselves and say we're doing a terrible job, but it's just building a picture of what's going on. And then there's an interesting point of, well, why might we not raise things? And we asked, how long did you think that the patients needed to stop before there was a benefit to them stopping smoking before surgery? And there's quite a spread of responses in the 4 weeks or more. Most people thought that you needed 4 weeks or more, or at least over 2 weeks, to get any benefit from stopping smoking. And there were people saying that, 6 months to a year before there's any benefit for surgery. The literature is relatively conflicting in this. There's no good randomised controlled trials saying what's better in terms of timing. We all know locally that some people will say, well, if they're smoking a week before surgery, I don't want them to quit because they'll just have so many secretions, they'll really struggle, so I'm not going to raise it at that point. And the evidence that's out there saying in the prospective series that if you quit within 2 months, your risk is actually the same as a current smoker. So although that doesn't sound like a positive thing, it sounds like quitting closer to surgery isn't harmful. However, then in a retrospective series, if you quit within 2 weeks of the operation, they found that you had more early complications than if you'd quit longer before that. So you can see why there's a lot of uncertainty amongst the healthcare professionals. And that's going to influence what advice we give people, and then also potentially the timing of it. Overall, I think we would all agree that the earlier that people can quit, the better. So preferably when they see the GP with a cough or whatever symptom they have, then preferably when they get to the respiratory physician, at each point it should be earlier than the day before surgery or their pre-op assessment. Do we think there's an issue with smoking cessation services? That's really the central point today, and the majority of people thought, yes, the access isn't as good as it could be to help people quit. So overall, up and down the country, we're saying our patients are smoking more than the average general population. And they're not managing to quit if they are current smokers when they're coming up to surgery. We're all referring to community services. Some of us are also having in-house support in the hospital as well. But again, there's sometimes that feeling of, well, it's a community service from the GP that should be provided. But we all think that if services were better, well, not all, but the majority think that if services were better, then the patients would have a better chance of stopping smoking. And what are we going to do from here? How are we going to go forward? I think it's reasonable that we all just, in our own units, look at what we're doing. It's never a bad thing to assess your own services. Maybe a local audit might be helpful. And look at whether it's possible to integrate any hospital services you already have into the same appointments, whether it's in a different department, but you can arrange it for the patient at the same appointment. If there's any possibility of doing that, I think that's a very reasonable way forward. And then really the actual reason we did this survey was because we felt there was a problem, and that we feel that there is a very deserving case for doing research into both how we help people quit and the timing of quitting. When we asked as a sub-question within this, the majority of people would be happy to recruit into a trial, and we specifically said using e-cigarettes as an adjunct to surgery, so not delaying the surgery and actually not researching into the timing of smoking cessation, but then saying to patients, okay, you want to quit smoking, great, here, have an e-cigarette straight away, bin the cigarettes, and then see how you go. And that's what we were looking at when we were designing the survey. Okay, thank you for your attention. If you've got any questions, then I'd be happy to take them.